Good morning. This is our group. We're here to discuss the direct clinical practice role competencies for advanced practice registered nurses.
Good morning. I am Raquel Bradney, and I will be defining the role competency of the advanced practice registered nurse in direct clinical practice. What is direct clinical practice? Direct clinical practice is the central competency of advanced practice nursing. It shapes the execution of the other 6 competencies. Preparation of direct clinical practice includes knowledge of pathophysiology, advanced physical assessment, and pharmacology. Direct clinical practice involves interaction with patients and families to promote health and well-being to improve quality of life. The goal of these interactions is to achieve better outcomes for individuals and groups of patients. Direct clinical practice refers to the activities and functions that advanced practice nurses perform within the patient-nurse interface. Patients includes family members and significant others also. Direct clinical practice includes consulting, collaboration, mentoring staff, and leadership staff and programs. Direct care activities include patient and family education, counseling, ordering labs, ordering medications, and performing procedures. The advanced practice nurse does not have to physically provide direct care to the patient, but the advanced practice nurse is engaged in the clinical practice. Thank you.
Good morning. My name is Kirsten Van Maal, and I will be reviewing the description of direct clinical practice. Within direct clinical practice, there are 3 primary criteria, which include graduate education, certification, and a practice that is focused on both the patient and the family. Within the 7 core competencies of advanced practice nursing, direct clinical practice is considered the central competency on which all the other 6 competencies are informed. Direct clinical practice is an essential component which lays the foundation for APNs to successfully enact, effectuate, and facilitate the other competencies, and is the sole component that lies between the primary criteria and the other 6 competencies. Interaction and clinical credibility are imperative elements necessary to facilitate consultations, collaborations, and leadership within the scope of the APN. Content of direct clinical practice differs according to each area of specialty, and the amount of time spent in direct clinical practice also varies according to each specialized area. There are 6 distinguishing characteristics of direct clinical practice, which include a holistic perspective, formation of therapeutic partnerships with patients, expert clinical performance, use of reflective practice, use of evidence as a guide to practice, and lastly, use of diverse approaches to health and illness management. Thank you.
Good morning. My name is Ainsley Fields. There are 6 characteristics of direct clinical practice for advanced practice registered nursing. The first characteristic is use of holistic perspective. Holism is defined as a deep understanding of each patient as a complex and unique person who is embedded in a temporarily unfolding life. This characteristic recognizes the physiologic, social, emotional, cognitive, and spiritual dimensions of every individual. It is the responsibility of the APN to promote continuity of care that focuses on each unique individual. In implementing practice strategies, the APN must take into account complexity of human life, the effects of social, organizational, and physical environments, the effects of illness, aging, hospitalization, and stress. Also to focus on quality of life and the functional abilities. The second characteristic is formation of therapeutic partnerships with patients. It is the responsibility of the APN also to encourage patients to participate in shared decision-making. In communicating with patients, the APN should use open-ended questions. It's important also for APNs to be aware of their own personal beliefs and how these personal beliefs affect and influence their relationships with patients. We should also incorporate cultural influences in order for biases to be avoided. One important aspect of effective communication is listening. Some patients are limited in their ability to fully speak for themselves. These would be some non-communicative patients. Examples of non-communicative patients would be infants, unconscious patients, comatose, patients with dementia, psychiatric conditions, or a patient that would be in severe pain. In practice strategies, the APN should use conversational style, therapeutic use of self. They should also encourage active participation in decision-making, incorporate cultural influences on healthcare, and advocate for the patient's perspective and concerns. The third characteristic of direct clinical practice is expert clinical performance. The expert performance of the APN includes clinical thinking, thinking errors and time pressures, ethical reasoning, skillful performance, and advanced physical assessment, education, adverse events, and performance errors. Practice strategies for this characteristic include seeking supervision with new skills, investing in deep understanding of patient situations, generate alternative lines of reasoning, always try to trust your hunches, and then also look into them. Be aware of when you are time pressured, because this is likely to cause thinking errors. Also consider multiple aspects of situations while treating. And always make sure to use technical equipment in a safe manner and know how to interpret data produced by monitoring devices. And lastly, always anticipate ethical conflicts.
Good morning. I'm Sarah Hillstead. The fourth characteristic of direct clinical practice of the advanced practice nurse is the use of reflective practice, utilizing positive and negative experiences to improve practice. Reflective practice is beneficial in many situations to increase knowledge and to expand the skills needed to practice successfully. Prospective reflection requires preparation, shows dedication and foresight on the nurse's part. Concurrent reflection concurrently with the situation. It shows flexibility and adaptation. We must work hard to meet the reflective guidelines, to decrease the fear of judgment within groups, to promote self-awareness and self-reflection skills, explore alternative treatments, integrate knowledge into future practice, and evaluate outcomes. We must address the barriers to reflective practice, including the lack of time and personal feelings. The fifth characteristic is the use of evidence as a guide to practice. Research competency is described as the skills and ability to obtain evidence-based knowledge. This includes using librarians, professional databases, and quality improvement guidelines. Research-sensitive practice involves research findings which are unstructured and casual. 3 steps involved: reading, evaluating, and adjusting. Evidence-based practice is done systematically and with precision. It fosters the profession. There are 4 steps: locating, translating, implementing, and measuring the outcome. Theory-based practice is also purposeful and comprehensive. It includes conceptual models, theory models, and mid-range theory models. The 6th characteristic is the use of diverse approaches to health and illness management. The advanced practice nurse must master interpersonal interventions, including providing support, affirmation, building rapport, and offering guidance. Therapeutic interventions, decisions of whether and how to treat patients. Individualized interventions based upon patients, blending individualized nursing care with standard treatments. Individual interventions include assessing the acceptability by the patient, past success, self-care ability motivation, side effects, costs, health aptitude, and recognizing and promoting information-seeking behaviors. Complementary and alternative medicines and integrative conjunctive therapy is important, as well as collaboration. Clinical prevention, population health focuses. Primary care prevention. Focus on prevention, counseling, screening, immunizations. Bringing up the difficult topics will help your patients in the long run. Thank you.
Hi, I'm Stacey LaCour. I'm going to give examples of CNMs and CRNAs using direct clinical practice. Midwifery can be traced back to pre-professional women. They were respected members of the community until the late 19th and early 20th centuries, when science would begin to dominate hospital services. High infant and maternal mortality rates were contributed to untrained and unlicensed midwives. To solve this problem, schools were created to educate and train midwives. As a result, the American College of Nurse Midwives had to redefine the practice and philosophy to emphasize midwifery and nurse origins of the role. CNMs enact direct clinical practice by the following. They manifest a high level of expertise in the assessment, diagnosis, and treatment of women's life cycles. They also form partnerships with the women they care for to empower them to be active members of their health care. For example, as you can see in the picture, the CNM is allowing the pregnant woman with preeclampsia to assist with determining diet and exercise needs that can fit her lifestyle to prevent further complications. Also, they incorporate science into clinical practice. In this picture, they are incorporating science into clinical practice. The CNM use evidence-based practice to determine the best position to alleviate pain in the woman who wants to have a natural childbirth. They also familiarize themselves with alternative and complementary therapies to assist with demonstrating a holistic approach to health care. For example, the CNM understands that Hispanic clients may require treatments to restore their hot and cold balance. They will not give hot medications to treat a hot illness. They exercise expert critical thinking and skillful performance. In this picture, the CNM recognizes when the fetus is in distress and she plans an immediate and safe delivery. They also can practice as primary care providers and leaders of maternity care homes. For the CRNAs, nurse anesthesia has been recognized as the oldest organized advanced practice nurse specialty. It has been provided since the American Civil War, but the first organized program for nurse anesthesia education was offered in 1909. CRNAs pioneered standardized postgraduate education, credentialing, and continuing education. They were the first nurse specialists to receive direct reimbursement for their services. It is explained by Callahan and Creamer that when anesthesia is provided by nurse anesthetists, it is considered nursing, but it is recognized as medicine when administered by anesthesiologists. CRNAs enact direct clinical practice by the following. They facilitate diagnosis. They also treat acute and chronic pain. They select, obtain, and administer anesthetics, adjuvant drugs, accessory drugs, and fluids necessary to manage the anesthesia, maintain physiological homeostasis, and correct abnormal responses to anesthesia or surgery. In this picture, the CRNA determines the correct dosage and type of medications to sedate a patient during craniotomy. They also monitor patients by selecting, applying, and inserting invasive and non-invasive monitoring modalities for collecting and interpreting physiologic data. In this picture, the CRNA is monitoring vital signs of the craniotomy patient to make sure the patient is not over-sedated. They also can manage airways. In this picture, the CRNA is placing an endotracheal intubation on a patient who deteriorates during a partial lobectomy. CRNAs also educate patients and families on the rationale for treatments and procedures related to mechanical ventilation, and they also release patients from the PACU.
My name is Tracy Mathus. I'm going to discuss direct care practice examples of the clinical nurse specialist, the primary care nurse practitioner, and the acute care nurse practitioner. One of the roles that nurse practitioners can assume is that of the clinical nurse specialist. This role was created to provide direct care to patients with complex diseases or conditions. It was also created to improve patient care by developing the clinical skills and judgment of staff nurses, and also to retain nurses who are experts in clinical practice. Expert clinical practice is the core value of this role, and the core strength of the clinical nurse specialist is providing complex specialty care while improving the quality of care delivery. The clinical nurse specialist must use advanced assessment skills and the integration of biophysical, psychosocial, behavioral, socio-political, cultural, economic, and nursing science into expert nursing practice. An example of this would be a clinical nurse specialist providing blood pressure management for a patient with hypertension while also considering that the patient is on a fixed income. Clinical nurse specialists are most likely to care for a patient whose diagnosis is complex or problematic, such as providing care to an elderly obese patient who has congestive heart failure and who's also received a renal transplant. The specialist must also possess the ability to evaluate the latest evidence and apply it in diverse ways to manage complex cases. Another example of this would be a clinical nurse specialist prescribing a new medication for a frequently admitted stage 4 cancer patient that has been proven to reduce infections by 32% in patients receiving chemotherapy. The primary care nurse practitioner. Direct clinical practice is the foundation of the primary nurse care practitioner's work. They must consider patient care in a holistic perspective. An example would be when caring for a patient with COPD who is wheelchair bound, the primary care practitioner also considers the patient's ability to come for appointments, show up for treatment, their support system or lack thereof, their financial ability for the cost of care, and the ability to care for themselves at home. They must also use expert clinical thinking. An example would be to make an appropriate diagnosis and formulate an effective treatment plan for a newly presenting patient with complaints of abdominal pain. They must incorporate the use of reflective practice, such as they will provide continuous care for an established patient, making changes to the treatment plan as needed when it reflects that an improvement can be made. They also use diverse approaches to guide practice. An example is that the primary care nurse practitioner understands that the treatment of hypertension among patients of different age, race, and health status will require diverse treatments for the same medical condition. For the acute care nurse practitioner, direct clinical practice consumes the greatest percentage of practice time. Their practice requires completion of a prioritized health history and comprehensive and focused physical examinations, such as the acute care practitioner in the emergency room that obtains a pertinent health history and performs an examination of a pediatric patient presenting with a 24-hour history of fever and diarrhea. The acute care nurse practitioner must perform a rapid assessment of unstable and complex health problems, such as in the emergency room, again, conducting a rapid assessment required to treat a 16-year-old patient with acute onset of shortness of breath and a history of asthma. They must then implement diagnostic strategies and therapeutic interventions to stabilize healthcare problems. For example, in the above patient, the 16-year-old, the acute care nurse practitioner makes a diagnosis that is accurate of acute asthma exacerbation and orders oxygen, NEP treatments, and steroids. Their practice includes modification of the plan of care based on the client's changing condition and response to intervention, such as the acute care practitioner that works in the ICU, changing the dose of IV propofol in response to a patient with falling blood pressure and high level of sedation. They must also collaborate with other care providers to demonstrate positive outcomes. For example, again, the nurse practitioner in the ICU collaborates with the intensivist, the pharmacist, respiratory therapists, nursing staff, case managers, etc., to determine the best treatment for each patient in the ICU. Thank you.
Hello, my name is Melanie Taylor. Today I will discuss current research on outcomes of APRN direct clinical practice. Examination of outcomes and performance are critical in the advancement of the advanced practice nursing profession. Surveillance is an essential component of direct clinical practice, which is carried out by all APRNs. APRNs such as CRNAs are dedicated to careful monitoring of patient status and are equipped to intervene to prevent patient deterioration. In a study evaluating patient outcomes of certified registered nurse anesthetists versus anesthesiologists versus team anesthesia, two outcomes were measured: inpatient mortality and complications. Anesthesia-related patient safety indicators such as death in low mortality diagnosis and failure to rescue from a complication of an underlying illness or medical care were examined. Results revealed that despite the turn towards solo nurse anesthetist practice, there was no increase in adverse outcomes in either opt-out or non-opt-out states. Mortality rates were lowered. The nurse anesthetist solo group had lower mortality rates than the anesthesiologist solo group in opt-out states, both before and after opting out. Certified nurse midwives also spend a great deal of their practice providing direct care to patients. They are skilled in implementing a variety of approaches in the management of illness and promotion of health. In a systematic review compiled of 11 studies, the care of
certified nurse midwives were evaluated. Results revealed that under the CMS care model, patients had a decreased risk of unfavorable outcomes. Risks such as hospitalization prior to giving birth and instrument-assisted childbirth were reduced. Interestingly, positive outcomes such as spontaneous vaginal delivery and breastfeeding were apparent. Thank you.